Is it Stricker or Stricker?
Stricker.
Thank you.
Thank you, Dr. Baker. My vision isn't as good as Dr. Phillips, so I'm going to try to use my computer to read my slides. And I'll try to press both buttons at the same time. I am the past president of ILADS, and I want to thank IDSA for inviting me to speak here today. My mission is to review the problems with diagnosis and treatment of Lyme disease in the IDSA guidelines. And I'm going to be covering 4 topics. It's a good thing I have this. One is the laboratory diagnostic test requirement and restrictions on the use of clinical judgment in Lyme disease. The second is the implausibility of persistent infection in Lyme disease. The third is the challenge to early Lyme disease treatment duration. And finally, challenge to late neurologic Lyme disease treatment. And just to give you an overview, and several of the panel members, including Dr. Medoff, asked, well, do you think these guidelines just need a little bit of tinkering, or do they really need extensive revision? And I think that the message that these guidelines give are shown on this slide. Lyme disease is easy to diagnose. Lyme disease is easy to treat. Persistent infection following short-course antibiotic therapy is, quote, highly implausible, unquote. And also the alleged danger of prolonged antibiotic therapy in patients with Lyme disease. And I think that because the guidelines give this message, they really need an extensive overhaul to change that message. So first, let's go to the challenge to the laboratory diagnostic test requirements and restrictions on the use of clinical judgment. And the guidelines state clinical findings are sufficient for the diagnosis of erythema migrans, but clinical findings alone are not sufficient for diagnosis of extracutaneous manifestations of Lyme disease. Diagnostic testing performed in laboratories with excellent quality control procedures is required for confirmation of extracutaneous Lyme disease. So let's look at how these laboratories are doing with their testing for Lyme disease. A study by Bakken et al. Published in 1997 comparing interlaboratory variation among 516 participants in the Wisconsin State Laboratory of Hygiene College of American Pathologists proficiency testing program reached the following conclusion. Our data indicated that the sensitivity and specificity of the currently used tests for Lyme disease are not adequate to meet the 2-tiered test approach being recommended. And because of the poor performance of these tests, the study went on to say, in conclusion, our results suggest that stronger measures need to be taken by the Food and Drug Administration to control the quality of commercially available Lyme disease assay kits. And right on cue, a study by Brown et al. Published in 1999 from the Food and Drug Administration reviewed studies of Lyme disease test performance published through 1998 and reached the following conclusion. Given the results seen with different manufacturers' test kits, interlaboratory results predictably show poor agreement. A test in 4 laboratories which used either IFA or ELISA indicated that neither interlaboratory nor intralaboratory testing were reliable. So to back this up, a study from Feld et al. Published in 2002 involving 337 microbiology laboratories in Europe reached the following conclusion. Quantification of test results and reporting of specific immunoblot bands showed high variability. Moreover, for some assays, a high number of false positive and false negative test results were reported by the participants. In view of our results, further standardization of Lyme disease serology is not just desirable, but is urgently needed. Moreover, stronger criteria for the validation of available test kits must be applied. And finally, a review by Stricker and Johnson published in 2007 of North American case control studies of commercial 2-tier Lyme testing reached the following conclusion. The 2-tier testing system endorsed by the Centers for Disease Control has a high specificity, 99%, and yields few false positives. But the tests have a uniformly miserable sensitivity, 56%. They miss 88 of every 200 patients with Lyme disease. An updated analysis, including more recent studies, found that the sensitivity of the 2-tier test system was even worse at 46%, and this sensitivity is far below the 95% cutoff required for an accurate diagnostic test, and much worse than the 99.5% sensitivity of commercial HIV testing. And to show you this in tabular form. These are the studies included, and I want to point out that they were all studies after 1993. They did not include the older ELISA and IFA tests that were referred to by previous speaker. There were 8 studies involving 435 patients and 951 controls. As you can see from this slide, the specificity was great, 99%, but the sensitivity was very bad, 46%, inadequate for a diagnostic test. Now, you've heard from previous speakers that this testing, the two-tier testing, may be good in certain stages of Lyme disease. And this is a version of a previous slide that looked much nicer before from Dr. Johnson that was presented at the Canadian Lyme Consensus Conference in 2006. And you've heard that in late Lyme disease, the two-tier testing does a lot better, 97%, 100% sensitivity in late arthritis or late neurologic disease. But as several of the panel members have commented, there are some problems with these results. One is that this is a very small number of patients, 33 patients with arthritis, 11 patients with neurologic disease. And there is, in fact, circular reasoning in this type of study, which was admitted by the authors of the study, who said that for late disease, the case definition requires at least one late manifestation and laboratory confirmation of infection. And therefore, the possibility of selection bias toward reactive samples cannot be discounted. So there is this kind of circular reasoning that you need a positive test to be included in this group, and then the test has 100% sensitivity. So, oops. Let's see. Now, this slide, also presented by Dr. Johnson at the Canadian conference, shows very eloquently all the problems with two-tier testing. It's insensitive in acute EM and possibly in early neurologic disease. It lacks antigens expressed only in mammals. It's complex, technically demanding, and costly. It's hard to standardize. Reading Western blots requires judgment and experience. Western blots are only semi-quantitative. Faint bands are difficult to interpret. It may require 2 blood samples. Appropriate use of IgM blots requires knowledge of the date of disease onset, and IgM blots are less specific than IgG blots. And some labs are inexperienced in properly setting blot development cutoffs. And all of these problems are reflected in, came out differently on the PC. In this statement from Aguirre Rosenfeld and colleagues, who said, relatively few studies using currently available commercial tests have evaluated the performance of the recommended two-tier testing on well-characterized sera from patients with extracutaneous manifestations of Lyme borreliosis. Comparison of sensitivities and specificities between studies is difficult due to the use of different antigen preparations and test methods and inclusion of sera from Lyme borreliosis patients with undefined disease duration and treatment history. So this testing is very difficult to interpret. For those of you who do AIDS work, you may know that the best way to evaluate an old AIDS treatment is to look at a new AIDS treatment, and the same thing goes for Lyme testing. So this is a study also presented by Dr. Johnson in Canada, looking at the C6 peptide ELISA and comparing it to the two-tier system that we have now. And if you look at the bottom line, this was a fairly robust study, 275 patients, and the sensitivity of the two-tier testing, as you can see here, was a mere 62.5%. Again, inadequate for a diagnostic test. The interesting thing about this slide, you heard from some speakers that in late Lyme disease, there's 100% sensitivity. Well, in this group of patients, and they had 91 who had late Lyme disease, the sensitivity of two-tier testing was only 81%. So not the 100%, 97% that you heard about before. Not really that good. Now, for those of you who think that the C6 peptide is a vast improvement, this slide is not very encouraging. You can see that the overall sensitivity for the C6 peptide was only 77.8%. So that may not be a big improvement on the current system that we have. Now, why do we have this problem with two-tier testing? Well, the IDSA guidelines rely on the CDC surveillance criteria that you heard about before for the use and interpretation of Lyme testing. The CDC, in turn, cites 2 pivotal studies to support the current commercial test system, one by Engstrom et al. For positive IgM results, and the other by Dressler et al. For positive IgG results. Angstrom and Dressler pegged positive test results to high specificity, 92 to 94% and 99% respectively, at the expense of sensitivity. In those studies, it was 44 to 75% and 83%. And thus, the two-tier surveillance test system, although highly specific, lacks the sensitivity required for an accurate diagnostic test. And so the next question is, should Lyme testing, should this inadequate Lyme testing take precedence over clinical judgment? And this gets back to the issue of positive predictive value of Lyme testing, which you heard about from other speakers. The guidelines state that regardless of the nature of the symptoms, a low positive predictive value can be anticipated if serologic testing is done for patients who do not reside in or travel to a geographic area where Lyme disease is endemic. Now, there are two problems with this statement. One was articulated by Kurt Reed in this review of laboratory testing for Lyme disease. And that article says, because Lyme disease incidence rates and vector abundance vary widely between different geographic areas, it can be difficult for physicians to have sufficient information to allow accurate assessment of pretest probability of Lyme disease for individual patients. And the other problem is shown more graphically on this slide. This is a study by Brownstein et al. Looking at the distribution of Ixodes ticks over the next 70 years and influenced by the changes in climate and global warming. And if you look at the pink portion of this slide, virtually the entire eastern part of the United States is going to be tick habitat over the next 70 years. So it will be impossible to say that a patient has not been in an area where they were not exposed to Lyme disease from these ticks. And this is a big problem with determining positive predictive value. Now, turning to the challenge to implausibility of persistent infection, you've heard a lot about this from Dr. Phillips. The guidelines state that the notion that symptomatic chronic B. burgdorferi infection can exist despite recommended treatment courses of antibiotics in the absence of objective clinical signs of disease is highly implausible. And I want to remind you of something that Dr. Luft said in passing, which is that Lyme disease is really a zoonotic infection, and these types of infections are programmed to be chronic infections. And therefore, it's not surprising that this organism has a number of mechanisms for chronicity, and they're shown on this slide. And I don't have time, obviously, in this talk to go into these mechanisms in detail. I refer you to the source material to read more about these mechanisms of persistence. And these mechanisms are responsible for the persistent infection that's been documented in numerous cases, as outlined by Dr. Phillips, and again shown here partly on this slide. And so it's highly plausible that Lyme disease causes persistent infection in patients who have persistent symptoms. The third challenge is to the early Lyme disease treatment duration, and here the guidelines say that each of the recommended antimicrobial agents has been shown to be highly effective in the treatment of erythema migrans and associated symptoms in prospective studies. So what are these antimicrobial agents? Well, the guidelines say that doxycycline, amoxicillin, or cefuroxime for 14 days is recommended for treatment of adult patients with early localized or early disseminated Lyme disease associated with erythema migrans. For amoxicillin, none of the trials cited by the guidelines used amoxicillin alone for less than 20 days. And likewise, for cefuroxime, all three of the cited trials employed a 20-day cefuroxime treatment regimen. So the recommendation to reduce treatment duration for amoxicillin and cefuroxime to 14 days lacks explicit evidence that effectiveness is maintained with the shorter regimens, and this portion of the recommendation has to be revised. What about doxycycline? These are the studies looking at early Lyme disease treatment with a 20 to 21-day course of doxycycline. And as you can see, the first study doesn't look bad, a 5% failure rate in the smallest number of patients. But look at the other studies and the failure rates on the right. 19%, 22%, 40%, 32%. This is not necessarily effective treatment for early Lyme disease. And if you look at an even shorter course of doxycycline, this is 10 days, in two studies, the failure rates were even worse, 46% and 31%. Again, this is based on an intent to treat analysis, which, as those of you who do AIDS work know, is the gold standard for analyzing these kind of studies. So what about, what about longer follow-up on these patients? And this is a slide that Dr. Wormser is very fond of presenting, showing the response to 10 days of doxycycline over 30 months. And as you can see from this slide, the response looks great. 90% of patients got better with a 10-day course of doxycycline. But the problem with this study is that it had 61 patients in the treatment arm, and by 30 months, half of the patients had either dropped out or been excluded. And that's the basis for saying there's a 90% success rate. If you look at an intent to treat analysis of the same group of 61 patients, you can see that the success rate is only 46%, which is a lot different from the 90% that's shown on the initial study. The fourth subject is the challenge to late neurologic Lyme disease treatment. The guidelines say that response to treatment is usually slow and may be incomplete. Retreatment is not recommended unless relapse is shown by reliable, objective measures. Now, the problem with this recommendation is that it's based on 4 open-label trials involving 96 patients who had variable durations of ceftriaxone treatment. And in fact, the outcomes in these patients was really poor. Only 7 to 35% returned to their pre-morbid baseline. So the recommendation against further treatment is really not supported by the outcomes in the studies. And along those lines, I want to show you some evidence about the risk of treatment in patients receiving IV antibiotics, because there's been a lot said about that during this hearing. This is a table that shows the published randomized controlled trials of IV antibiotic or placebo treatment for Lyme disease. There are 366 patients who received an average of 38 days of either IV antibiotic or placebo. This corresponds to over 11,000 days with an intravascular device or an IVD. There were 15 patients out of 366 who had significant adverse events for an adverse event rate of 4%. And this corresponds to an adverse event rate of 1.3 per 1,000 IVD days, which is really no different from other studies of other diseases using this kind of therapy or IV therapy. And also, if you look at the difference between patients receiving IV antibiotic versus the patients receiving IV placebo, there was no difference in the complication rate. So it does not look like giving IV antibiotics makes this a much more dangerous treatment. Now, I want to say a few words about the systematic errors and misleading statements in the IDSA guidelines. There are, and they're shown on this slide, exaggeration. An example of that is the guidelines say that the vast majority of patients with early neurologic, cardiac, or arthritic symptoms of Lyme disease have a certain outcome. This translates into something like 60 to 65% of patients, so this is definitely an overstatement. We've already talked about the circular reasoning, defining a condition with a positive test, and then saying that the test has 100% sensitivity. And then you've heard more about small sample sizes, data selection, and reliance on expert opinion. These are more reasons why these guidelines need to be revised. So in summary, science does not support the inadequate diagnostic testing for Lyme disease recommended by the IDSA guidelines. Science does not support the inadequate treatment of Lyme disease recommended by the IDSA guidelines. Persistent infection causing persistent symptoms is plausible in chronic Lyme disease, and prolonged antibiotic treatment is relatively safe and justifiable in chronic Lyme disease. Thank you very much.
Thank you, Dr. Stricker. Questions from the panel? Dr. Madoff?
I'm just curious about exactly what you mean by clinical judgment and what criteria you use to make a diagnosis of chronic Lyme disease.
I think there are a number of symptoms that are consistent with chronic Lyme disease. And again, I think you have to make a distinction between screening for this disease and also the patient sitting in your office who's just come back from a vacation in Cape Cod and has a number of symptoms that may not be hard evidence of the disease, but together suggest that there may be something like Lyme disease. And then there are tests that can be done that to support that diagnosis, and we can discuss that more if you like. But I think that Lyme disease, as the CDC says, is a clinical diagnosis, and you have to use your clinical skills to make that diagnosis.
Well, could you tell us what those other tests are?
I mentioned that the testing endorsed by the CDC and IDSA is based on certain criteria from the Engstrom and Dressler studies. There are other criteria also from the Engstrom study and the study by Ma that was referred to previously that give a different diagnostic test criteria or set of criteria for a positive test. And those tests are done by labs that are proficient in testing for Lyme disease. They have a very high sensitivity and a very good specificity, and that can be used now. Also, there are newer tests coming along. Dr. Luft is working on a proteomic system along with Dr. Barber as well. That testing will probably be much better, but that's in the future.
Dr. Carini, did you have a question?
Yeah, you mentioned the Bakken study from 1997 and the Feld study that was done in Europe in terms of the variability of different labs with regard to the two-tier testing. Are those data still valid, or have things improved?
Those data
and the data from Europe may be not as relevant here.
That's true because there may be different strains that they're testing for. However, those data are using the exact same test kits that are used today, the Mardex kit, the Immunetics kit. All of those tests are the same today as they were in 97. Nothing has changed.
Is there any monitoring of variability among labs?
I've not seen a follow-up to those studies, so I don't know.
Dr. Sanders?
I know for time reasons you had to skip over this area, but going back to the stealth pathology of B. burgdorferi, I haven't seen that same description in the close relative, the other Borrelias that cause tick-borne relapsing fever or louse-borne relapsing fever. In fact, what I think I've seen described is that as the antigenic variation, as the antigenic shifting goes through its cycles, that the body clears that. Why would this be different than its closest relatives?
I'm not sure how well those spirochetes have been studied compared to Borrelia burgdorferi, but I know that the Lyme spirochete has a large number of functional genes. Most of them have an unknown function, and probably that confers much more of a potential for resistance for the Lyme organism. That's probably the best answer I can give you.
Dr. Lantos?
You had mentioned that in the 4 clinical trials that the adverse event rate was similar in the placebo group as in the drug group. But correct me if I'm wrong, but the adverse events that were reported were deep vein thromboses and Lyme infections. So these are not effects we would expect to see in people who don't have central lines, right?
That's correct. But the point is that the effects, the side effects from the treatment did not significantly increase the risk of just having an intravenous catheter. And in fact, one issue is that getting the antibiotic may have decreased the complications of the catheter because Lyme infection was one complication which was not seen in most studies with ceftriaxone.
But if the alternative is no catheter, right, then you would not expect to see these adverse events.
That's true. You would not see the 4 to 5% adverse events that you see in those studies if you didn't have a catheter. That's correct.
Just one comment on your map. Your map was the location of the ticks in the left-hand side of the U.S. map, and we have lots of ticks, Lone Star ticks in the Lone Star State. I just want to make a comment that I think a map with distribution of disease rather than distribution of ticks would have been more helpful in your presentation.
I don't think we really have that map over the next, projected over the next 70 years. Again, that's the point of that study. The other thing about that study is that they only looked at the eastern part of the U.S. They did not look at anything else. So,
well, I was talking about now, not in 2080. So the blue part of the map, and maybe Dr. Johnson can take back to the CDC that it would be nice to have, at least for the reported cases, an updated map. A case map, not a tick map. Because we have lots of ticks, but not as much disease as in some of the other areas of the United States. So thank you very much for your presentation.
I just wanted to mention, by the way, Betty Maloney was responsible for a number of the slides in my presentation. I wanted to give her credit.
Thank you.